I'd like to talk about skin and soft tissue infection today and hopefully educate you about some new developments. I have nothing to declare, no conflicts. So I'd like to mainly review skin and soft tissue infection recognition and management in long-term care patients. I'll differentiate different types of cellulitis. There is a relatively new approach to sort of classifying cellulitis, a way to approach the potential etiologies and what empiric antibiotics should be used. I'll talk about other conditions that might mimic cellulitis, in particular stasis dermatitis and other causes of soft tissue inflammation, and show you a good clinical test for determining how much stasis dermatitis might be playing a role. It's very common. I'll also talk about recognition and management of other comorbid conditions that contribute to soft tissue infection. And I'll review a bit of MRSA because that has impacted recent guidelines on management of soft tissue infection, although it may not have a huge impact on the long-term care population. And I might skip some of that at the end. So in long-term care, as you know, there are many challenges. Patients are just getting older and older. Some days at work, I think I see everybody's over the age of 80 some days, I think. And you know, as patients get older, their skin gets thinner. They have more comorbidities. There's malnutrition. They're more compromised. There's maybe a bit more trauma. They fall. They get banged up easily, and the lower extremities get neglected. I find some people are completely unaware of their feet, and I think there's a lot more infections in these patients. Some of the conditions that we see that contribute to recurrent or one-time episodes of soft tissue infection, chronic venous stasis is very common, lymphedema for one reason or another. Heart failure can exacerbate fluid retention and increase risk. Skin conditions like dermatitis, psoriasis, eczema, very common, and fungal infection, different types of tinea of the feet. Diabetes with peripheral neuropathy is something that many patients we see have that particular risk factor for infection, and of course peripheral vascular disease too. But the good news in your patients is they usually have a pretty easy history. They haven't gone anywhere. They usually haven't been bitten by anything. And there's usually minimal other risks and exposures. This is a good example of infection due to those 0.1% of bacteria on the back of your hand. But actually as many as 20 or 30% of us are colonized with group A strep, and 20 or 30% of us are colonized with Staph aureus. And those are the main pathogens that cause almost all of the infections I'm about to show you. MRSA is less likely in your patient population, and usually it's not a surprise. I think you have patients who are known to be colonized with MRSA, or there's known to be some MRSA in the facility, and it's probably unlikely that you have surprise cases of MRSA in someone who's been in long-term care for a while. The other good thing is that a lot of these infections can be treated with oral medications. And we're all going to hype the beta-lactams today, but it's true that the beta-lactams maybe aren't the most potent oral medicines. There are some medications, though, that are very potent oral medications, and where oral basically equals IV. They have high bioavailability, and you're able to give doses that are equivalent to IV. So that is one good thing, and some of these drugs are listed there. Metronidazole, the quinolones, Bactrim, Doxy, and Clinda. And some of these you'll see me mention today quite a bit in this talk, because Clinda, Bactrim, and Doxy are all pretty good for treating MRSA and some other skin infections. Okay, so I'd like to talk about an approach to cellulitis today, and how you should think about patients that you see where there's redness of their leg. Is it cellulitis? Is it always cellulitis? Well, it isn't always. You need to consider the other possible causes of erythema in the legs. And stasis dermatitis is certainly one that's very common. We see in the OPAT clinic, we see sometimes 4 or 5 new cases a day of erythema and cellulitis, and it's amazing how many people have stasis dermatitis. Superficial thrombophlebitis is something that can cause some erythema as well. Often that's in the setting of soft tissue infection though, and many of those patients have both. We see some drug reactions. I've seen quite a few drug reactions that mimic cellulitis. I've seen some good vasculitis cases, particularly leukocytoclastic vasculitis. It's thought to be infectious. And then some patients present with DVT. That's really not that common to have DVT. I think, I see quite a few patients where the emerge docs order Doppler ultrasounds to look for blood clots, but it's not too common that DVT actually mimics cellulitis, but it can happen. Ischemia much more commonly. So much more common to have arterial insufficiency as a cause of pain, erythema, tenderness, and there may be a bit of infection there, but I've seen cases where there's probably no infection at all. It's all ischemia, but it's a bit of an unusual presentation with some erythema and pain. And then we, of course, see some other strange presentations of pyoderma and gout, of course, which can mimic anything. And I think it's interesting today we've talked about urinary tract infection and respiratory tract infection and how we often don't know the causes, and we're trying to sort out who needs to be treated. This is a really recent paper in, let's see, I think it was JAMA Dermatology, looking at the misdiagnosis of lower extremity cellulitis. And this was just published. It's an online publication so far. It just came out a couple weeks ago. But I've been following this literature because we're doing almost a similar study that's actually now we're done the data collection portion of it out of the OPAT clinic. Just looking at how complex most soft tissue infections are and how hard it is to have an accurate diagnosis. In this paper, they looked at adults who were admitted to a few different hospitals with a diagnosis of cellulitis. They excluded anybody who had an abscess or a wound or trauma or anyone who was already on intravenous antibiotics. Looked at 260 patients, and 30% really that were admitted with the diagnosis of cellulitis, 30% of patients were deemed ultimately to not have an infection. And of those 30%, 92% received unnecessary antibiotics. And in fact, 85% of them probably didn't need to be in hospital. So it just shows the burden of uncertainty with some of these patients who present with a red swollen leg. So this case is a good example of someone who had no response to antibiotics and had taken multiple courses of antibiotics. I remember when I saw this patient, they'd already been on a course of cephalexin, a course of clindamycin, and a course of doxycycline, and really, things weren't any better. And that's their limb. There it is up close there. So this is a good example of stasis dermatitis. And this leg is a very good example of some of the skin findings you'll see. The patient had chronic pitting edema. You usually get it with pitting edema because stasis dermatitis is a complication of venous disease and chronic venous stasis. People with chronic lymphedema usually do not develop this. You'll see usually erythematous patches. There'll be some scaling, eczematous-like patches. There'll be maybe plaques. It could be flaking a bit. Often it's bilateral. Usually these patients are not sick. Usually the white blood count's normal, and often the CRP is normal too. And if you have a leg looking like this, it's not getting better on antibiotics. You have to think about stasis dermatitis. That's the same patient there. You see both legs now. It's bilateral. There's some excoriation. Risk factors, as I said, venous hypertension and chronic venous stasis, chronic dependent edema, obesity. These are the main risks for this. Congestive heart failure is an exacerbating condition, but it's not. People who just have heart failure and CHF-related edema don't tend to have this. Similarly, people with nephrotic syndrome, low protein, and other reasons for peripheral edema tend to not have this. So usually it's with venous hypertension and venous disease. So there's a really dramatic example of super chronic stasis. You might have patients like this in the nursing homes that you've seen. I mean, there's quite a few patients like this out there. Very scaly, dry, eczematous-looking skin. It's a clinical diagnosis. Even if you biopsied this, it's hard to get a specific diagnosis. And it is often kind of a diagnosis by exclusion. But there is one clinical test that I've learned to utilize in the OPAT clinic, and that's to see what happens with these feet when you elevate these patients. So here's an example on your left of some erythema of this lower extremity when the foot is down on the bed, and then after elevating for 20 seconds, you see that most of it blanches. And so erythema due to cellulitis does not blanch. Erythema due to cellulitis remains erythematous with elevation. This is a very useful test. All of us do this all the time in the OPAT clinic, and we can sometimes quickly just say, oh, this person needs no antibiotics at all, as does this one, because there's almost no erythema left with elevation. Sometimes some of the erythema goes away, sometimes half of it, but occasionally, like this case, all the erythema went away with elevation. This patient needs no antibiotics whatsoever. And I'm seeing this patient in the OPAT clinic. They got sent in for IV antibiotics. There's another example. This is the one that I showed a few slides ago with elevation on the right. Vast majority of the erythema fades. So it's a simple bedside test that can help quite a bit to tell you that we need to focus our efforts on other aspects of treatment here, and antibiotics aren't the main thing. So the treatment is to treat the stasis dermatitis, which is to treat the edema, and often put some hydrocortisone on this. So a typical thing I would do is put 1% hydrocortisone on the area of erythema once a day or twice a day, and some kind of compression stocking. And we like to use 2B grip stockings in the OPAT clinic. And I don't know if 2B grip is readily available in the long-term care facilities. It's like you've probably seen the yellow line and blue line stockings. Those are a white stocking that literally have a yellow and blue line on them in a roll. 2B grip's the same manufacturer, it's the same company, but the material is thicker, more elastic, it has more compression, and it comes in a variety of sizes. It's sort of a flesh-colored, beige-colored stuff that in the hospital we use it all the time. Just pull off 3 feet of that, cut it off, and pull it on like a tube sock. And it gives pretty good compression. And if you double it up, it gives compression that's almost 8 to 10 millimeters of mercury with a couple layers of that. So it's a very handy thing. We go through rolls of it in the OPAT clinic.
How often do you leave it on?
Oh, you can leave it on I tell patients, all day, take it off to put the cream on. It's a temporary thing. It's going to last a few days. You could even launder it once and maybe get another use out of it, but eventually the elasticity is shot. And I mean, all these patients, I tell them this is a temporary tool. I'm going to use this, and I tell them to go get a compression sock, a more formal compression sock. And we could talk about that too later. So there's the treatment, as I said. So, elevation and compression for the edema. Some patients, I'd say maybe 1 in 4 or 1 in 5 patients that I see who has a big problem with peripheral edema, I actually put them on diuretics. If someone does have some heart disease, if they got a relatively full or high JVP, if there's other evidence of volume overload and it looks like there's someone who could use a diuretic. It's amazing how much fluid you can diurese out of some people safely. But not everybody who has edema in the lower extremity can tolerate a diuretic, so I certainly don't put everyone on diuretics, but I do use them occasionally. Obviously, you have to monitor renal function and potassium a bit until that's stabilized. This condition, I only learned about this condition a few years ago. You have a question?
Yes, it's regarding those compression stockings like 2B grip.
Yeah.
Do we need to do anthropic index? Like that's what usually asked, should we do before we...
Yeah. That's a good question. I would say no. For just a 2B grip, I would say no. It's not much compression. It's only about 8 millimeters, 6 to 8 millimeters, a single layer. I mean, if you can feel a pulse, you don't need ABIs. Many of these if you can't feel a pulse, the patient should have ABIs anyway, because it's likely that there's some arterial insufficiency contributing to their problems. So I think we should order ABIs, certainly in the hospital, to have a look at people's arterial circulation. You're going to do very little harm with a single compression tubing grip. For more formal compression, yes, you have to get ABIs before that. I've actually never seen a catastrophe from compression stocking, even though I know a lot of the wound care nurses are very nervous about that. So lipodermatosclerosis is actually it sounds like a mouthful, but it's lipo, subcutaneous tissue, dermato, skin, and sclerosis, scarring. And this is actually the end result of people who have venous hypertension, venous insufficiency, and chronic venous stasis for a long time. Some of them develop scarring of the subcutaneous tissues, and it's a typical cause of sort of hourglass legs that you see, where people can be they can be obese, and they can be edematous, but they've got skinny ankles, and like this patient here, and the ankles are skinny because they're so scarred down, and if you were to feel these ankles, it's like feeling a tree trunk of a little pine tree or something. They're just woody and indurated and dense and tender, and often these patients present with pain. And in this actually photo, you hardly see any redness. The photos sometimes don't do it justice. But I mean, again, this is a person that was sent to the OPAT clinic for intravenous antibiotics, as was the last. But there's not that much redness, but there's a lot of pain. Over time, lipodermatosclerosis leads to scar tissue, and it's a more challenging problem to treat because there has been permanent injury to the subcutaneous tissue. Here's the patient from the photo, and what happens to her foot if I elevate it. And quite a bit of the erythema goes away, but not all of it, but quite a bit does. So, and this gentleman here, this is actually a relatively healthy-looking kind of 55-year-old man who was sent to the clinic, who had terrible pain. Both legs, it came on relatively acutely, and his pain was way out of proportion to what you see, to just touch it. And it was this case that actually made me recognize this entity of lipodermatosclerosis, because I had to research what's the other cause of just terrible pain and erythema of the leg. And it turns out, once I sort of realized this about 10 years ago, I make this diagnosis quite a bit. And it is one of the causes of terrible, painful, inflammatory, soft subcutaneous tissue. And it's really not an infection. It's sort of an acute episode of stasis dermatitis, really, that's involving the subcutaneous tissue as well as the skin. So, when patients aren't getting better on oral antibiotics, they don't always need IV. Why not improving? Well, the common reasons for failure, I find, number one is inadequate drainage or lack of surgical intervention. We see people all the time in our clinics where they just need a bit more drainage of a subcutaneous collection or a bursa space or something like that. The wrong syndrome diagnosis, and certainly stasis dermatitis is the number one thing we diagnose that isn't infection. By far, that's the most common. Not recognizing the underlying primary disease process. So, sometimes there are primary skin conditions that are the main problem, and then not treating comorbid conditions. So, some of these patients, you put them on antibiotics, and they're really slow to get better, but you need to manage the edema and the discomfort and the stasis dermatitis, and have them use compression, elevate their legs, use topical anti-inflammatories, and sometimes systemic anti-inflammatories, and then they start to get better. And if you don't add in these other modalities, often the patient doesn't respond to cephalexin. But if you put it all together as a package, and I often tell many patients, I say, you've got 4 problems, right? You've got an infection, that's the easy thing to treat. You've got terrible chronic edema, you've got chronic venous stasis, you've got a skin condition called stasis dermatitis, and often they'll have some open wound, some stasis ulceration. And I'll go through how we're going to manage each one of those 4 or 5 things. And really, the antibiotics is the easy part. They're off those in 5 to 7 days. It's the other stuff that might take weeks or months. So always ask, what's the process? Attempt to make a syndrome diagnosis. Is it cellulitis or something else? And so once you think it is an infection, then also think about what else is going on. Is there something deeper infected? And in your patients, you're probably not going to see too much of the other stuff, the tenosynovitis, maybe some bursitis, but not too much probably. Septic arthritis, some of the things that we see. Abscesses that need to be drained, etc. So, a red leg isn't always just cellulitis. Sometimes there's deeper, more complex problems. But if you think it's cellulitis, then the next question you ask, so we've asked, is it an infection? And then we've asked, is there some other kind of infection? And then if it's just cellulitis, now we ask, is it purulent or non-purulent? And so that's the new approach to sort of how to approach cellulitis these days. So more IDSA guidelines, no protesters protesting these guidelines, but they first came out in 2011 and updated in 2014. And it's actually a very good document. They have a nice approach and a real nice quick summary to all the different things, everything from impetigo to ecthyma to a lot of different things to bubonic plague. They even have that in here. So they have just everything covered, as most guidelines do. But they have a nice discussion of just cellulitis, and so basically the approach to cellulitis now, which I'm actually really happy that. To see these when they first came out, because I'd actually recognized this. I think quite a few clinicians had recognized this, that the patients that come in and they just have pretibial cellulitis and their leg and everything else is intact, those are usually strep. The ones that come in and they have, a pustule, a boil, penetrating trauma, an open wound, something like that, those are more likely to be staph. And so we clinicians noticed this, like I noticed that over a decade ago and taught medical students that. But it's become now the way that we approach cellulitis. So non-purulent, no skin lesions. Much more likely to be beta hemolytic streptococcus. Might still be Staph aureus, but not too often. Pretty easy to cover both though, and we'll talk about how we're going to cover both. Purulent cellulitis, where there's pustules, wounds, drainage, maybe strep, but most likely Staph aureus. And then you have to assess what are the risks of MRSA. And really that's one of the driving factors behind these new guidelines is the whole MRSA problem, and how in a lot of emergency rooms and out there in the community, MRSA is so prevalent. It's not that prevalent in the long-term care, but we'll talk about how we're going to think about MRSA in a minute. And then Erysipelas, which is really a type of non-purulent cellulitis that's almost exclusively beta hemolytic strep. And I'll talk a little bit about what Erysipelas is. So non-purulent cellulitis. So this is a typical case. So if you look at the good leg, you see someone who's got obviously chronic edema and some stasis dermatitis, even in the good leg. And then in the involved leg, diffuse erythema, and it's circumferential and right up to just below the knee, not very well demarcated at all, and with diffuse erythema, but the main area of involvement is pretibial. So just sort of a classic look for a streptococcal cellulitis. Now here's another cellulitis that I'd say is a non-purulent cellulitis, even though you're seeing a bit of a wound develop there on the left leg. The lateral aspect of the left leg looks abnormal there. What's happening is that's sort of an epicenter, and it's beginning to blister there. And a lot of streptococcal infections will eventually blister. There'll be some bullae or blistering and some superficial skin breakdown. With bad cellulitis, you'll often get some desquamation. The skin peels like a sunburn or blisters up and peels, and some of the upper layers of dermis can be damaged. But early on in this infection, this was a non-purulent cellulitis, and the blistering doesn't turn it into a purulent cellulitis. This, I would still be managing this as a non-purulent cellulitis. Here's another non-purulent cellulitis there. Obviously some really chronic looking legs there. Even if you look at the good leg, there's dramatic hyperpigmentation and atrophy of skin and skin changes consistent with chronic venous stasis. So non-purulent, mostly beta hemolytic strep, staph aureus could be in there, but most likely beta hemolytic strep. And then, you know, most cellulitis that we see is beta hemolytic strep or staph aureus. And it's rare to have some other organism isolated or to eventually realize you're dealing with a gram-negative or something. It really isn't very common. I would say, even in the OPAC clinic where we see, you know, 2, 3, 5 a day, I would say I see one, you know, Klebsiella or Pseudomonas or Serratia or something funny. I probably see one of those every 6 to 12 months only. You know, they're really not that common where it's a coliform or something else. You see Pseudomonas colonizing a lot of wounds, but in non-purulent cellulitis to be due to Pseudomonas, I can say basically never. And same with anaerobes. So the treatment options. So cephalexin is really the drug of choice here because it's going to cover beta hemolytic strep and MSSA. And if you treat those two things, that's, you know, you've got the right spectrum of activity for the vast majority of soft tissue infections that you're going to see. With cephalexin, 500 QID is the standard dose. Rarely you might dose reduce down to 250 QID with significant renal dysfunction in a 90-year-old or something who weighs 102 pounds and that kind of thing. I often don't even dose reduce it. I do give 1,000 QID sometimes. And certainly in your big patient, a 300-pound person who has pretty significant soft tissue infection. And I don't think I've ever had anyone complain of nausea or vomiting. They just, if you can take 500, they seem to be able to take 1,000. And for many patients, I'll treat them with 1,000 QID for 2 days or something and then step them down once I see them turn the corner. And then clindamycin can be useful for non-purulent cellulitis in someone who's got a significant beta-lactam allergy. Actually, before I go to clinda, I'll just say a lot of guidelines you look at talk about the use of dicloxacillin in the US. But we don't have that here. We have cloxacillin here, which I rarely prescribe actually just because it's not that well tolerated. It also doesn't cover strep as well as the diclox does in the US. And I don't know why we never adopted the use of dicloxacillin in Canada. Diclox is superior to cloxacillin. I basically never use it. I just use cephalexin. If someone does have a significant beta-lactam allergy though and you can't give them beta-lactams, then clindamycin is an option. A lot of different doses to range there, all the way from 300 TID to 600 TID, depending on the severity of the infection, the age and weight of the patient, those kind of things, how much they can tolerate. Bigger doses are harder to tolerate. So the 300 QID is kind of my go-to small dose, and 600 TID is kind of my go-to big dose. Moxifloxacin can actually be used to treat soft tissue infection. It's actually got not a bad spectrum, especially for non-purulent cellulitis, because it covers strep really well. It's actually licensed and approved for soft tissue infection, but we're trying to get you to not use too many fluoroquinolones today. So it's down on your list.
I have a question about mox. I heard in the past that you're not allowed to treat anything below diaphragm with
So that refers to the anaerobic spectrum of activity of moxi, because the anaerobic spectrum of activity of moxifloxacin is kind of like the anaerobic spectrum of activity of a penicillin drug or clindamycin, where that sort of approach, like those drugs are good for the anaerobes that come from above the diaphragm. The anaerobes below the diaphragm, Porphyromonas, Bacteroides fragilis, Prevotella, that might be resistant to clinda and moxi, that's where you use your amoxiclav and your flagyl. But that's all anaerobic stuff, and it doesn't pertain to the soft tissue use of it as a soft tissue drug. Bactrim actually is excellent for Staph aureus, but not so good for strep, and I don't really use it for, like, alone. I wouldn't use Bactrim alone to treat non-purulent cellulitis. And doxycycline, similarly, you do lack some efficacy against strep, and I don't usually use it alone for non-purulent cellulitis. Those are going to be used more in the purulent cellulitis. There's a good example of some Erysipelas. We all think of Erysipelas on the face, right? And in fact, there's three. Erysipelas is talked about in Europe. When people say Erysipelas, it's almost used synonymously with the word cellulitis. They don't actually differentiate different conditions. Some people talk about Erysipelas only when they're talking about facial infection, but I see lots of facial infection that isn't Erysipelas. Usually there's a pustule, and then they get periorbital cellulitis or something, and but it's not Erysipelas. But if you have this condition occurring on your face with the typical butterfly sort of rash that started on one cheek and shot across the bridge of the nose and down the other, and it's just glistening, gleaming red, fiery red and raised, that's typical textbook Erysipelas, but that process can happen anywhere on your body, and we see it on the legs and elsewhere all the time. It's quite dramatic, just a glistening, raised, palpable border. Very well demarcated. You can just see the dermis is involved. So this is bacteria spreading through the upper layers of dermis, as opposed to most cellulitis where the bacteria spread through the subcutaneous tissue. So the bacteria is spreading through the dermis. And this is almost exclusively Streptococcus. And there's another example. And the reason that it's brought up is that in the guidelines, in the IDSA guidelines, and clinically, when we see something that's obviously beta hemolytic strep like this, you could actually treat this with amoxicillin, or just streptococcal, anti-streptococcal agents. So if you see erysipelas or lymphangitis that's clearly sort of beta hemolytic strep, often you can just focus on that. A lot of streptococcal infections are quite classic. The patient comes in, they give you a great story of being ill and flu-like for a day before they even realized there was an infection on their leg. Often they vomited once and had 2 loose poops and felt like they had the flu and went to bed, and then the next day they got up and saw they had cellulitis. Almost always that's group A strep. There's the lymphangitis. You've all seen lots of lymphangitis. This is a typical kind of patient who's post-mastectomy axillary node dissection with streptococcal lymphangitis in her arm. Great example of it. There it is, spreading out right all the way across her chest. It's all abnormal from radiation therapy and surgery and scar tissue and everything, but so the lymphatic drainage channels are all funny. Here's a couple more cases of a spread. These are all probably streptococcal infection. The one where on your left where it's leaping from the lower leg into the groin. The one on the right, it's going up his arm and then leaps right into his axilla. Streptococcal infections.
So Erysipelas is all your strep? That's what you're
These are streptococcal infections. Yeah. Vast majority of the time. The good news is Keflex is going to cover staph too, but you could, if you had to, use amoxicillin, high dose even. Now this is an example of more of a purulent cellulitis. There was a boil, a little abscess. If there's wound, if there's penetrating trauma, these are usually staphylococcal, but we would always cover strep too. And many times I've actually swabbed some of these and grown both staph and strep. And then if there's risk factors for MRSA, you have to consider treating that too. If there's no real MRSA risk, you can just use cephalexin. You could use clavulin, clindamycin. Those would all be okay. Another example of something that's definitely there's a skin problem, right? There's a wound, there's drainage. That's actually a very severe infection. This guy was admitted. He was septic. So, one thing about patients who present with boils and furuncles and abscesses, they don't all need systemic antibiotics, and localized uncomplicated abscess could be managed just with drainage alone and wound care. And there were some interesting initial articles in the pediatric literature at the beginning of the MRSA sort of epidemic that looked at, and they actually identified a 5-centimeter rule. So if you have a little abscess or pustule or boil, if the soft tissue involvement was less than 5 centimeters in diameter, there's no need for systemic therapy at all. Just drain it, lance it, compress it, treat it locally. IND and hot compresses, and it'd be fine. But certainly if a patient has any systemic symptoms, if they have fever, if they're unwell in any way, they definitely, even if it's small, then they do need systemic treatment. And when do you cover MRSA 2? Well, there's a wound there. That was a little abscess that kind of drained spontaneously. It's hard to see. There is some spread that goes up the medial thigh there posteriorly. So with you don't really have to worry about your patients and all this sort of epidemiology of MRSA and where it is. But in the long-term care facility, I think most of your patients are screened, and so they're either already documented to be colonized with MRSA, or maybe they were colonized once, and even if they were documented to be cleared after that, I'd still be just careful with those ones. Or if there's some MRSA contact or some other person who's colonized in the facility. I don't know what percentage of long-term care residents in VHA have MRSA colonization that is active. It'd be interesting to know that. It's probably not very many. When to treat MRSA or when to consider MRSA though. Like I said earlier on, I said I wasn't sure how many of you were ever surprised with you swabbed something on a patient and it turns out it is MRSA. I'm not sure how often that happens. Certainly we do have to consider MRSA in patients from high-risk groups or close contact with high-risk individuals. When I consider treating MRSA mostly is when the red flags go up when I meet the patient. Things like, they were fine and now all of a sudden this is like their 3rd episode of furunculosis in the last 3 months or something. Or at the time when they're coming to see me, they've got 2 active infections, one in their buttock and one in their other thigh. Or one on their face, that kind of thing, where it's just all of a sudden there's been a dramatic change in the pattern of soft tissue infection in this patient. Or they were on something and they're failing to respond to standard antibiotics like Keflex. So these are the big red flags. Usually it's multiple furuncles or sites of involvement all at once or recently. So if you have anything like that going on, you should think about MRSA and get a swab. So just to review, the current MRSA that's out there, our local strains, they're almost universally sensitive to Bactrim. 97% are sensitive to Bactrim, 96% sensitive to Doxy, only 80% sensitive to Clinda. So if you do think something's MRSA, you're better off to use Bactrim or Doxy empirically. You'll probably never need to use rifampin in the long-term care setting. I used to use a bit more of that than I do now, even I've kind of dropped using it. There were some studies looking at using that plus Bactrim or Doxy in really serious patients. I would only do it if I was really trying to keep somebody off IV antibiotics. Linezolid's always an option, but it's very expensive still, although the price is coming down. In fact, didn't it just go generic last week, actually, or something? Recently. Yeah, it's come way down. So we might see more linezolid. You have to worry about drug interactions with linezolid. It's got significant drug interactions with all kinds of SSRIs and a wide variety of medicines. I do consider decolonizing some people if you do have any patients. Any of you ever had to, how many of you have treated an MRSA patient or have seen an MRSA patient in the hospital, in your long-term care facility? Just a handful, eh? Half of you. So, some people, if they do have recurrent problems, you could decolonize them. I usually don't decolonize someone after a single episode. I'm not sure what, and I get called, I don't think VHA has a policy stating that you must decolonize someone who has MRSA, but I do get calls from some doctors about long-term care patients about how to go about doing it. And there's a variety of ways to do it. And I can talk more about that if you want at the end. Certainly, you know, I do decolonize many patients. We see patients who have recurring problems, and to break the cycle, it's worthwhile to try to decolonize them. Or if there's other scenarios where you know, I see sometimes the whole family's symptomatic, and getting repeated courses of Bactrim and needing things lanced and drained, or if there's compromised people in the house.
So if they're colonized and they don't have boils that are draining, do I leave them alone without decolonizing?
Yeah, you can. If they're asymptomatic and known to be colonized but asymptomatic, then technically there'd be no need to decolonize them unless you were asked to try to decolonize them for infection control reasons, right? Yeah?
So I think if they're colonized, they can't have surgery at rehab. They have to have two sets of swabs demonstrating they're decolonized.
Yeah. So people can have surgery, but you're right. To prepare someone for surgery or for other infection control reasons, you're right. You should you're instructed to do a decolonization attempt and then prove decolonization with 2 screening swabs. I occasionally see referrals or get called about, you know, patients where they are failing to become decolonized. So then it's like, how do you manage them perioperatively, and how can you reduce the risk of MRSA wound infection, that kind of thing. And it's a reason for people to, you know, if they get surgery and they're colonized with MRSA, they're the last one on the slate that day. They have to be the last person out of the operating room because it's a terminal clean. So it's a real big rigmarole. And often they need vancomycin as their perioperative prophylaxis instead of Ancef. And, you know, there's a whole bunch of things that have to be taken into account if you can't decolonize them. But you're right, you may be asked to decolonize some patients. Some patients that are challenging to decolonize, if someone has an open draining wound, I don't try to decolonize them because their infected wound has to heal up first. People who have like, you know, we see some patients, they have different indwelling devices, whether it's some chronic G-tube that's colonized or something. I mean, you're never going to decolonize that at a G-tube site. There's a variety of things. People with respiratory tract colonization, that's really hard to eradicate as well. People who've had chronic positive sputums, really challenging. You need systemic antibiotics if you're even going to try. Okay, so this paper came out a year ago about treatment of uncomplicated skin infections, but it pertains mostly to just all comers who come into an emergency room. And they looked at Clinda versus trimethylsulfa. So they're actually deviating a lot from, you know, our beta-lactam message today. But that's because of the risk of MRSA in some of these emergency rooms. And if you gave Keflex to everybody who came into an ER in Detroit or something, you know, for their soft tissue infection, you'd have a high failure rate. So they're looking at Clinda versus trimethylsulfa. It was a randomized double-blinded study. They looked at cure at 10 days, and look at how many patients had abscesses. 30%, 53% had cellulitis, and 15% had both. So half the patients had some kind of abscess. So right away, that's a lot different than the typical sort of patient around here. And Staph aureus was grown in 44%, and of the Staph aureus, 77% was MRSA. So this was a multi-center double-blinded trial. So it just shows how prevalent MRSA is in some places. But what it tells us, though, is that Bactrim and Clinda were both approximately equal, around 80% cure rates. So 20% failure rate, though. Probably those failures were strep infections, because the Bactrim really wouldn't cover strep that well. So no difference in efficacy. So one of the reasons I present this paper is I don't want you to read something like that and then think that Bactrim and Clinda are the ways to treat, basic cellulitis, uncomplicated cellulitis, like they call it, uncomplicated cellulitis. Because really the Bactrim misses strep, Clinda misses 20% of our MRSA here in Victoria. There's a better way to do this. And I would never use Bactrim alone, really, if I'm looking at a non-purulent cellulitis or if I think streptococcus is one of the organisms. So, as I said earlier, a lot of our patients and a lot of your patients in long-term care are going to have multiple problems. So, just to summarize the general management, treat with antibiotics according to the cellulitis type and whether or not there's an MRSA risk. If there's any abscesses or boils or anything that needs to be drained, that's crucial. And also, don't forget about all the comorbid conditions. Think about edema reduction with elevation and compression. Use diuretics if you can or if it looks appropriate, given the patient's volume status and renal function, etc. Do everything else that needs to be done, optimize their blood sugars, do the wound care, treat skin conditions like stasis dermatitis, treat fungal infection. It's amazing how many people have, tinea pedis, and some patients have the typical tinea pedis in the web space with maceration and wet web spaces, and that should be treated. It's been shown if you swab those, many of those patients are colonized with staph and strep in the web spaces. And I also see patients that just have diffuse fungal infection, of their foot with dry, scaly feet. I'm just going to skip these next ones. Yeah, just a couple. Hey?
I see a lot of patients that come through the foot, leg, and ulcer clinic with gangrenous stoves, and they're on clindamycin indefinitely, it seems, just months and months. Is that
Yeah.
the way we do it?
No, so some of those patients, we struggle with some of the patients that come in with gangrene. They need an amputation. And, I can think of 2 or 3 even in the last year that came through foot and leg ulcer that kind of fit this description, where the patient didn't want an amputation, and, the surgeon's involved, and it's just so hard to have things happen. Often they've got gangrene, they've got osteomyelitis, there's a bone sticking right out into the breeze.
But they're 95 years of age.
Yeah.
They're not going to get an amputation.
Yeah, sometimes they're not. And so I would like to get those patients off systemic treatment eventually and use just topical therapy, which now we use sort of we use iodine-soaked gauzes onto the gangrenous tissue. But some of them just have a smoldering foot infection that really, where there's a sort of a chronic cellulitis at the interface between the tissue that's alive and the tissue that's dead, and there's just kind of this inflammatory process there. And certainly clindamycin would not be my favorite choice if I had to put someone on a chronic oral antibiotic to prevent sepsis and further recurrent soft tissue infection in their foot. I'd like to use a beta-lactam or something a bit safer than that. But given the organisms and what's going on, I know I've seen some. I can probably think of one patient that you're referring to.
So if they've been on clindamycin for 2 months, is it worth switching to kettlebells?
Well, you could try based on culture. Sure, you could try. Yeah.
Can I ask one more question?
Sure.
Bursitis, common bursitis like electronol bursitis, bursitis, is there any role for an antibiotic in those situations? Would you just
If it's
localize to the bursa? Hot and red and tender and all?
well, a lot of bursitis that you might see is just inflammatory bursitis. And then the stuff we see is where there's septic bursitis. And, a lot of people have inflammatory bursitis from some trauma and irritation, and that can be treated just with some non-steroidal anti-inflammatories and, ice packs and whatever. But if it's septic bursitis, that needs antibiotics, and the bursa often needs drainage if it has fluid in it. We see the real whoppers, and we can recognize them from the doorway now because it's just there's such a pattern of infection from the bursa. They get cellulitis up there and up here. It's this exact pattern. We see it all the time. We drain that and treat with antibiotics. Usually Staph aureus is the organism, and some bursa infections take a long time to settle down, and I've had patients require 2, 3, 4 weeks of antibiotics before their bursa's before the infection part of it's all settled. had a really bad case last week. That there is a drug reaction. I'm going to skip it. That is leukocytoclastic vasculitis. That's erythema nodosum. And that's bursitis. So that's actually infrapatellar bursitis. And this is right before I lanced it and drained it 2 days ago. Okay. I'm going to skip this one and just go to the summary, 2 slides.
Oh, can you tell me what that last one was?
Well, that's just that's a patient with chronic venous stasis, chronic edema, chronic stasis dermatitis, and now there is soft tissue infection there, and that's a non-purulent cellulitis. It almost looks like a bit of Erysipelas-like sort of change there. I think that's probably a streptococcal infection of the leg. So I put that up as an example of what I thought was clinically it was probably streptococcal infection. This particular patient has this happen, you know, every 4 months. And I have just this one slide because we do see some patients who certainly have recurrent strep infection of a limb. And sometimes it's an upper limb, like after lymph node dissections, but usually it's lower extremity. And prevention involves, you know, lymphedema control or venous stasis treatment, meticulous foot, nail, and skin care. Get podiatry involved often. Treat any fungal infection that's there. And then many of these patients, some of them get quite sick quite quickly and with strep infection. And quite quickly it turns into a bad thing. This is the kind of patient I give them a prescription and say fill it and have the Keflex at home and be ready to take it. And I usually prescribe 1,000 QID for 8 doses, then 500 QID for 5 days, and so that they can start on treatment immediately once they realize that they're getting another episode of their cellulitis. And we do have the occasional patient where they just have, it's so frequent that we just can't keep them out of hospital or out of the OPAT clinic or whatever. And there's actually a good trial. It had an acronym that I can't remember. I was glad somebody finally did the study because ID doctors for 30 or 40 years have been doing this. And they finally did a study to show that it's actually appropriate and useful. And that is to use penicillin prophylaxis to prevent recurrent streptococcal soft tissue infection. So penicillin, 300 milligrams BID, and this doesn't happen anymore. And I have probably 2 or 3 patients right now on chronic penicillin, and I think we all probably do. So that's that slide. In summary, consider other causes of rash. Make sure you're confident with the process. Think about stasis dermatitis and lipodermatosclerosis. They're very common. The diagnosis is predominantly clinical. Remember that elevate the leg test I showed you, and do that at the bedside, and see if you think most of what the erythema is blanching, then it's probably more of a stasis dermatitis. Then if you think it's cellulitis, differentiate purulent and non-purulent. That helps guide tells you what the most likely bacteria are and gives you a bit of an approach. If it's non-purulent, it's almost certain to be beta hemolytic strep. Erysipelas and lymphangitis are types of non-purulent that are usually beta hemolytic strep, and you can really target therapy in those conditions. Purulent cellulitis is usually staph aureus. MRSA isn't that common, but you're going to encounter some of it, and you might have to think about it, and you might have to choose antibiotics. But the good news there is that there are some excellent oral antibiotics for treating MRSA available to you, particularly Bactrim, Doxy, or even Clinda if you know sensitivities. And don't forget about all the comorbid conditions. I find that's the thing we do the best in the OPAT clinic, is identify and treat all these other conditions that just get completely ignored by the emergency room doctors. So to help the patient actually get better and then prevent the next episode of cellulitis. Okay.
Take some questions.
Yeah, some questions.
About purulent cellulitis that's over 5 centimeters that you've done incision drainage, and you don't think it's MRSA, but MSSA.
Mm-hmm.
What are the antibiotics you use?
So if there's no real MRSA concerns, and the good news is, purulent cellulitis that you've lanced and drained, you should culture that, and you're going to have culture results in 24 to 48 hours. Cephalex and a first-gen cephalosporin is going to cover the MSSA. That's all you need most of the time. If I'm trying really hard to keep someone out of the hospital, I might use clindamycin or something. But if you think it's MSSA, cephalexin's fine. Yeah. Yeah.
Has there ever been an attempt to make a vaccine against group A strep?
Oh yeah, they're still working on that. Yeah. Yeah, they've been working on it forever, and they are still working on it. And if they do eventually have that, it'll be something that probably everyone will get. It'll become part of a childhood vaccination regimen. I had a patient in my office this week who's 22 and has a problem with acute rheumatic fever. We took her off penicillin 4 months ago, and she had at the age of 21. And she's had a relapse. And we talked about the vaccine. And she's very knowledgeable about the research going on the vaccine field. Karsten?
I just want to make a comment about the vaccination. It'd be great, but I have an incredible amount of things that you don't develop immunity to. I think vaccines are a bit of a pipe dream for a lot of these.
Yeah, I don't know if we'll ever do it. I know.
Staph aureus.
Yeah.
You don't develop immunity.
Yeah. Yeah. We can't, I mean, Kirsten's right. I mean, the reason we don't have a vaccine is because our own bodies are incapable of generating a protective immune response, right? It's not like most of the other viruses, like most of the 73 strains of entero and rhinovirus that are out there, you only get once in your life. Because you get it once, your body makes a protective immune response, and you never get it again. And we could make, so anything where your body's doing that, they can easily make vaccines against those viruses. It's just, there's no real need. But things your body can't make a protective immune response against, it is hard. HIV is another example. Although they are making some headway there too. Any other questions? Thank you.
Great, thank you.